First, I want to thank you for just providing such a great segue into my talk. Today I'm going to be presenting about my work using the Guideline Elements Model, or GEM, to explore the potential clinical impacts of differences of interpretation within guidelines for the care of premature infants. For this talk, I have no conflicts of interest to disclose. And as you just heard, our collaborators were the Yale Center for Medical Informatics and the Center for Biomedical Informatics at the Children's Hospital of Philadelphia. And what we did is we performed abstractions at both sites. The planned implementation of the GEM-CUT guidelines at the Children's Hospital of Philadelphia Center for Biomedical Informatics, which Dean just talked about, provided an impetus for the study. When we investigated the relationship between guidelines and clinical decision support, we found that guidelines are being increasingly used to support medical decision-making. Consistent guideline interpretation can help to decrease inappropriate variations in care, and that's one of the national healthcare quality goals. And adherence to guidelines is associated with improved healthcare outcomes. However, if the intent of the guideline is difficult to ascertain, it's hard to follow the recommendation, and it's also hard to determine if a recommendation is being followed. We believe that clarity in guidelines to be important, and that by comparing guideline abstractions, we would be able to identify areas where lack of clarity could affect clinical care. For the study, we had three research objectives. First, we wish to identify areas of divergent interpretation within the guidelines. Second, to categorize these differences. And finally, to extrapolate the potential clinical effects of these differences of interpretation. For the study, we compared two American Academy Pediatrics policy statements, and these were abstracted independently at the Yale Center for Medical Informatics and the Center for Biomedical Informatics at the Children's Hospital of Philadelphia. And these guidelines were associated with premature care, namely respiratory syncytial virus, or RSV, and retinopathy, prematurity, or ROP. To perform these abstractions, we use the Guideline Elements Model. This model contains over 100 elements with a hierarchical XML-based schema and provides a structure to the knowledge contained in guidelines. Previous work at Yale Center for Medical Informatics has demonstrated that GEM markups of the same document do contain variation, but has not explored the effects of variation on clinical care. So moving on to the abstraction process, which Dean kind of alluded to. First, the policy statements were reviewed by extractors at both facilities. Second, we used an application called GEM Cutter to mark up the policy statement into the GEM hierarchy. And I apologize if I used policy statement and guideline interchangeably. One of the types of guidelines the American Academy puts out is policy statement. They have slight differences, but they're not really important to this study. And then once the GEM Cutter markup was accomplished, we produced a report of the abstraction using a GEM XML Extractor Transform, XSL Extractor Transform. These reports facilitated translation into the human-readable format and also helped to facilitate comparison. And then here we can see a screenshot of the GEM Cutter application, which allowed us to parse the information within the guidelines into the GEM elements. The screenshot was taken of our abstraction of one of the recommendations from the retinopathy of prematurity statement and demonstrates the development of the GEM logic element from the original policy statement. And you can see the first screen has the policy statement, the second screen contains the XML GEM schema, and the third screen contains the knowledge elements that have been extracted. And kind of as a translational process. From this translation, we developed we used the GEM Extractor XSL Transform to produce a report of the same recommendation. You can see that all the clinical information is organized with the GEM elements below the original text, so you preserve the continuity of the document. Using the reports, we performed a side-by-side analysis to determine areas where the interpretations were different. We then located the portion of the guideline which was the root of the interpretation difference, and then we classified each interpretation difference based on the cause for the lack of clarity. And the three categories we found were conflicting, which were areas of the guideline that had recommendations that were completely incompatible, ambiguous, which were areas which the interpretations could be the concept could be interpreted in more than one discrete way, and then vague, in which cases really the concepts that we tried to interpret had very poorly defined boundaries. Overview of the findings, we identified 9 total interpretation differences, which we believe to have clinical impact. 7 of these were located within the ROP statement, and only 2 were in the RSV statement. ROP statement is significantly longer and contains more recommendations, so there was more material within which to detect the interpretation differences. And during the rest of this presentation, I'm going to be talking about 5 of these differences and to address the potential clinical impacts. Before going into that, I just want to touch briefly about some of the background information you kind of need to know to understand why these guidelines have clinical impact. A couple of the terms that are important: ROP stage, which is a description of the severity of the disease on a scale of 1 to 5, 1 being least severe, 5 being most severe. ROP zone, which describes the location of the disease on the retina. And Zone 1 is the most centralized and most concerning portion, and Zone 3 is the most peripheral and least concerning portion. And then also plus disease, which refers to tortuous blood vessels on the retina, and that's an indication of severe progressive disease. Finally, RSV season. RSV kind of has a cyclical nature. It's most present between November 1st and March 31st in all areas of the country except for in Florida. So, moving on to the first of the recommendations that I'm going to be discussing, or the first of the areas of divergent interpretation. We have one of the conflicting recommendations, which was found within the ROP statement. Recommendations 4 and 5 within the ROP statement both give guidance on when to indicate treatment for retinopathy of prematurity. Recommendation 4.5 says treatment is suggested if there is plus disease in zones 1 or 2. And within recommendation 5, there's more specific treatment indications involving stage as well as zone and the presence of plus disease. You can kind of see that these are slightly different. From this, we built a recommendation matrix. And using this matrix, the light blue are the areas that are concordant interpretation. The gray, which that's better up there, the gray are areas where there was no recommendation given within the guideline, and then the shaded areas are areas where we had divergent interpretations. Focusing on the area stage 1 RP with plus disease in zone 2, we can see that there are vastly different clinical recommendations given based on our interpretation of the guidelines, and that's based on which recommendation we chose. Moving on to second of these differences was ambiguity of interpretation. We interpreted the term prematurity differently within from each of the sites. This resulted in different recommendations for each of the sites depending on whether or not you were considered premature. This difference would have resulted in different recommendations being given for 2,000 newborns based on the weight less than 1,500, birth weight less than 1,500 grams, or 17,000 newborns based on birth weight between 1,500 and 2,000 grams based on the 2008 National Vital Signs statistics. You can kind of see one site interpreted 35 weeks, whether the other site interpreted 38 weeks as the definition of prematurity. We also found ambiguous interpretation of the term first RSV season. This was interpreted at Yale Center for Medical Informatics as any season you lived in. If you lived during any point during a year, if you were born during an RSV season, that counted as your first RSV season. However, at Center for Biomedical Informatics, only if palivizumab was given in a previous RSV season, that person was considered to have lived through an RSV season. And again, we developed a recommendation matrix which helped to identify the areas where there were differences of interpretation could have clinical effects. Again, the blue areas were concordant interpretations. The red areas, in this case, it's only a potential difference. Depending on whether or not they had been given palivizumab, there may or may not have been a difference that could affect clinical care. And this affected infants between 7 and 23 months of age who would otherwise have qualified for palivizumab. Moving on, there's 2 other interpretation differences just to talk about, and these were the vague concepts. We interpreted the concept of worse RRP differently. At one site, it was thought to be more severe than a specific type of RRP, more severe than Zone 2, Stage 3, while at the other site, it was thought to be more severe than the previous exam, so almost a progressive effect. And the other interpretation different is kind of a vague term or vague concept was regression of RRP. And similarly, at YCMI, we thought that it was that retinopathy of prematurity was no longer present, was regression of RRP, while at CBMI it was thought to be a transition to a less severe stage. So just we kind of thought about for discussion. The differences of interpretation we found could potentially result in different recommendations for clinical care based on the same guideline text. And these differences would make it difficult to compare adherence because we're really talking about apples and oranges in some cases. We also found that when using guideline abstractions to build decision support, it may be useful to look for areas of interpretation, areas that are interpreted differently or can be interpreted differently prior to implementation, and having a second independent abstractor can help to identify conflicting recommendations and vague or ambiguous concepts. And just in conclusion, by comparing the policy statement markups, we identified several areas of conflicting, ambiguous, and vague concepts that related to the interpretation of the clinical care recommendations, and absence of clarity within these policy statements can affect how clinicians interpret recommendations and potentially the care that's recommended to our patients. Okay, thank you.